Okay, I think we'll get started. Thank you everyone for joining. This is, I think, the fourth session of this academic year. And again, we have Lena, one of our thrombosis fellows, to present for us. And the topic for today is May-Thurner syndrome. I'm sure many of us will have questions for her. So Lena, take it away.
Great. Everyone can hear me okay? Okay, perfect. So today I'll be talking about thrombotic May-Thurner syndrome. It's an area that is interesting because we've had a few patients who have had May-Thurner syndrome, and I wasn't really sure about what the evidence truly was for treatment of May-Thurner syndrome and sort of what the outcomes were. And so it was a topic that we chose or decided to go into today. In terms of what we'll be talking about today, so we'll be talking first about the pathophysiology, then a little bit about the epidemiology, diagnosis, and the chunk of our chat today will be about treatment. So sort of differentiating between anticoagulation, catheter-directed thrombolysis, endovascular procedures, and post-procedural anticoagulation, and what evidence does exist for both sort of proximal DVT as well as for May-Thurner, as it's a little bit different. So what is May-Thurner syndrome, otherwise called Cockett syndrome or iliac spur syndrome or iliac compression syndrome? It's basically a chronic condition that results in chronic venous symptoms or DVT caused by a compression force, so a pulsatile extrinsic venous compression by the arterial system. So usually, in most cases, we think about the left iliac vein being compressed by the right common artery or iliac artery, though sometimes it can also be on the right side, with most common physiology there being compression of the IVC by the right common iliac artery. And that's usually against a bony structure in the iliocaval territory. So most commonly against the spine, and we can sort of see an example of that here on the right. It is important when thinking about chronic venous compression that we rule out other causes of extrinsic compression, extrinsic compression. So pelvic masses, uterine enlargement, aortoiliac aneurysm, retroperitoneal fibrosis, or osteophytes. In terms of the stages of May-Thurner, so important to recognize that iliac vein compression without structural vein changes are actually very common in the general population, and many people will have it, and it does not mean that they will develop May-Thurner syndrome, which is when you actually have true symptoms or DVT associated with this vein compression. Typically, stage 1, which is that compression without those structural changes, is asymptomatic. In stage 2, you get venous spur formation. So you can sort of see what those look like in this image on the right side here. So you get these lateral spurs, anterior spurs. They're basically these intraluminal fibrous bands that form within the veins and result in restriction in the venous flow. Usually the stage is also asymptomatic, except in cases of like significant exertion. So like if they're running, they may have some symptoms, but for the most part, usually not having significant symptoms in this stage, though they're at higher risk. And then truly having venous obstruction with DVT, edema, formation of secondary varicose veins in stage 3, where you will develop more chronic symptoms even at rest or acute symptoms of DVT. And as we know, most patients present in stage 3, and in terms of diagnosis, most of the time they present with acute DVT. That doesn't mean that a lot of patients without chronic symptoms don't have it. It's just not the patient population we tend to diagnose. In terms of the epidemiology, so we don't actually know exactly what the incidence and prevalence of MTS is, because a lot of patients that we have with MTS actually aren't diagnosed with MTS, but we do know that it is highest among women 20 to 40 years of age in terms of when it's first diagnosed. So in terms of the data that we have right now, a lot of review studies quote that clinically recognized MTS accounts for about 2 to 5% of all DVTs, but very likely this is an underestimate. And we know this because in many studies that have looked at, generalized imaging findings for asymptomatic patients, as well as looking sort of at the original study that was done by May and Turner back in the 1950s, spurs and compression are noted in sort of 22 to 25% of patients. This little trial on the right side here. So it was just a little study done in the Journal of Vascular Surgery of 2004. It was a retrospective study looking at 50 asymptomatic patients presenting to the emerge for unrelated reasons. So, had a CT abdo-pelvis for abdominal pain, really. And they did know that 24% of patients had greater than 50% compression, and these were not patients who had DVT. And 66% of patients greater than 25% compression. So what the compression really means in terms of actual predisposition to MTS and sort of what our cutoffs are is still not really clear at this time. However, development for thrombotic MTS or DVT in MTS is really related to very similar risk factors as the DVT risk factors that we already know. So female sex with additional estrogen-related provoking factors. So, in the pregnancy period on OCPs, scoliosis, because they think it probably shifts the spine a little bit, it can result in increased compression of that iliac vein, dehydration, hypercoagulable states, and radiation exposure, with some papers, which I'm not going to go really into today, indicating that maybe patients with MTS have a higher prevalence of these hypercoagulable states and hereditary thrombophilia specifically compared to other patient populations, but I didn't really go into that much further for this paper. In terms of the clinical features that we see with May-Thurner syndrome, so really just sort of any kind of chronic venous symptoms, usually one side more than the other, symptomatic DVT despite anticoagulation, so sort of PTS type symptoms or symptoms that persist despite being started on anticoagulation. DVT involving the iliac veins. So, we really have to think about this in patients who have really high up sort of iliofemoral DVTs with iliac involvement. Post-thrombotic syndromes, much higher prevalence of PTS in the MTS population compared to those who do not have iliac compression. Recurrent ipsilateral DVT after cessation of treatment who have otherwise negative workups or no other reasons for recurrent DVT. And then low incidence of PE has been reported as well due to the apparent protective effect of venous stenosis. So in terms of the gold standard for diagnosis of MTS, I actually don't really know if this is available or something that is actually used in Vancouver, but every review article that I've looked at has said that intravascular ultrasound is now the gold standard, just because it can do a 360 view and isn't impacted by sort of the direction that you're looking, which, is a problem with venography. So sort of classic catheter-based venography, which was the old gold standard before intravascular ultrasound became the bigger, more sensitive and specific thing about 10 years ago. Catheter-based venography is still very sensitive and specific, though, and is a very close alternative to IVUS. And more specifically, if they are able to do a pressure gradient across the area of stenosis and are able to achieve a pressure gradient of 2 millimeters of mercury or greater, that is when it is considered clinically important, because as I said before, many patients do have some degree of compression. It's not exactly clear at what point, if you're just looking at stenosis alone, that correlates with actual clinical outcomes. Most of our patients do have an ultrasound, which diagnoses the initial DVT, but very limited in its ability to actually detect iliac compression, whereas CT venography and MR venography are both very sensitive and specific. I will note that there are many more studies looking at CT venography, and the actual prospective validation studies for MR venogram are quite limited. So, some researchers would warn that yes, MR venography is likely just as sensitive and specific as CT, but has low reproducibility or may have low reproducibility and has not been adequately validated to say that it is for sure as good as CT venography. I had sort of alluded to this previously, talking about the challenges of diagnosis of May-Thurner syndrome, just because there are so many people who do have some degree of iliac vein compression, and it likely is a normal variant, and knowing sort of at what point it is, enough stenosis to say that this is the reason that someone has a blood clot and someone has higher VTE risk is challenging. Given the high prevalence of some degree of compression and some degree of those fibrous sheets or these spurs forming, so 22 to 25% in those earlier studies that we talked about, and the fact that the prevalence of VTE is much lower than that, right? I mean, we think that probably mild venous compression is unlikely to cause increased risk of VTE. So in a review article done by Harbin et al. Just this year, published in the Journal of Thrombosis and Hematology, he sort of looked at 4 different papers, which were comparing the degree of iliofemoral venous compression and stenosis between patients who had May-Thurner syndrome and controls. And he found that on average, in patients who had May-Thurner syndrome, this is the average, not like the range, but he was looking at sort of like high 60s, low 70s for the average in regards to the amount of iliac compression in those who did have MTS. And in those who are asymptomatic, an average is 28 to 52%. So that's a very big range, of course. Like those numbers, like 52 is almost double 28%, but 52 is very close to 68. And so like really our true understanding of what degree of stenosis is actually related to MTS is still quite limited. And so we have to keep that in mind when we see patients who have some degree of stenosis. All right, so now the bulk of my talk is going to be about treatment, and I will tell you now that this became largely a interventional radiology talk when I was doing the research for it, and there is very limited good information looking really truly just at May-Thurner syndrome, and very limited information looking at anticoagulation. And so in generalities, for anticoagulation, there are no studies comparing different types of anticoagulation for those who have May-Thurner syndrome or the appropriate duration. Generally, they say basically you can just treat MTS like any other kind of DVT or VTE. So DOACs agreed to be the preferred agent as long as there aren't contraindications, even though most of the studies that we have up to date, people with MTS are treated with warfarin just because of sort of the era in which a lot of the MTS literature was produced. Currently, review articles recommend, like I said before, sort of doing a workup as well as appropriate for DVT and VE or VTE, based on sort of the absence or presence of provoking factors, and then using that to sort of base your duration of anticoagulation for DVT and VTE. I did find that interesting because, I sort of assumed that people who had this known iliac compression would be, most people would recommend indefinite anticoagulation, but this does not seem to actually be what I read based on the multiple review articles that I went through. In terms of the risk of recurrence off anticoagulation, it is noted to be higher without endovascular procedures. And I will go through some of those studies that talk about the endovascular procedures, but a review article by Mako in 2019 published in VASA said, traditional treatment with anticoagulation and compression therapy does not resolve the thrombus and underlying mechanical compression seen in MTS, and therefore definitive therapy usually requires revascularization. And similarly, Harbin in 2019 said there was a high failure rate on anticoagulation alone, which they feel is probably partially mechanical and partially as a result of the pulsatile nature of the obstruction from the right common iliac artery. And there are no real trials looking at anticoagulation alone versus anticoagulation with CDT or endovascular procedures in the population of MTS. So, yes. In terms of the existing data that exists for using catheter-directed thrombolysis in proximal DVTs, it's difficult to challenge really like just catheter-directed thrombolysis from endovascular procedures, as all these trials essentially either included endovascular procedures, including stent insertion, in their main trial data, or had recommended stent insertion for patients who had significant iliac vein stenosis of greater than 50%. But the main trials are really the Torpedo trial, the CABINET trial, the ATTRACT trial, and the CABA trial. And I will go through those briefly because I think it is important to sort of talk about general proximal DVTs and how those are managed, the evidence for those, and how those are related to the guidelines, and sort of differentiate that from May-Thurner syndrome because the evidence is much less, but the recommendations are very different for MTS compared to the general population who has proximal DVTs. So I will be going through both of those for the remainder of the talk. So in regards to the Torpedo trial, the interim results were published in the Journal of Endovascular Therapy in 2012. I don't think they ever actually published final results, but basically it's an RCT that was assessing percutaneous endovenous intervention and anticoagulation to anticoagulation alone in patients with symptomatic proximal DVT, so popliteal and more proximal than that. In terms of how they decided on the percutaneous endovascular intervention, they basically used this algorithm on the right here. And so they said that all patients with symptomatic DVT, depending on if they had preserved venous anatomy and a fresh clot versus distorted venous anatomy and venosclerosis, they would either get straight to stenting, or if they had fresh clot, they would receive catheter-directed thrombolysis for extensive clots with multiple segments involved. Or if they were not, then you would go down sort of this middle arm here, and depending on if they had venous insufficiency or anemia, they would get just trellis, which is basically a thrombectomy device without thrombolysis. Or if they did not, they would get angiojet or trellis, which is sort of pharmacomechanical thrombectomy or thrombectomy. And of those patients who had residual venous stenosis post-lysis, those patients would also get stenting. And so all these patients who did have any sort of distorted venous anatomy, venosclerosis, or venous stenosis would also end up with stenting in this population. Of note, and what was interesting, was that all the patients in this trial did receive IVC filter prior to intervention, and the outcome they were interested was recurrent VTE and post-thrombotic syndrome at 6 months, so a pretty short interval. In terms of the anticoagulation used after, so aspirin was given in addition to warfarin for all patients who received endovascular procedures of any type. And then if they had a stent put in, they also received clopidogrel for 2 to 4 weeks. So they would be on sort of triple therapy for 2 to 4 weeks, and then sort of dual pathway therapy thereafter. And they were seen at 1 week, 1 month, and at 6-month intervals thereafter. In terms of the patients, they were able to get 92 in the control group, 91 in the intervention group, and of those in the intervention group, 27 had stents placed. There were only 3 patients lost to follow-up, and 11 patients did die, 5 of PE and 6 of cancer. And there was no significant difference in terms of PE between the 2 arms. The mean follow-up was 30 months. In terms of the actual results, so the Torpedo trial really did point towards significant benefit in terms of long-term prevention of PTS. So 29.6% in the control group had PTS versus 6.8% in the intervention group, which is associated with an absolute risk reduction of 22.8 or number needed to treat of just 4.4. And the severity of the PTS was also to be decreased in the intervention group. Recurrent VTE was also decreased, which with an absolute risk reduction of 11.5%, number needed to treat of about 9 patients. In terms of complications, they're mostly related to IVC filter insertion. So a number of patients did have some fresh thrombi that were included within the actual filter itself, but they said there was no actual IVC thrombus on top, and the majority were able to have their IVC filters removed. Interestingly, they did not comment on bleeding, which I think would have been very interesting to know because they had certain patients on triple therapy and certain patients just on warfarin alone. So not sure why they didn't really comment on that. But from the Torpedo trial, people were quite confident that there was some benefit for proximal DVT and the use of catheter-directed thrombolysis.
Sorry, Alina, do you know how long they had an IVC filter in for and after the procedure?
I did, but I don't remember anymore. I think that because a lot of the early trials did have IVC filters that were put in, and some of them were removed before they went home, and some of them were kept in for longer. I can't remember which one this is, but I can look it up after for sure. The next study was also published in 2012, and this is looking at longer term outcomes, so 24 months as opposed to 6 months. They were looking at catheter-directed thrombolysis versus standard of care for acute iliofemoral DVT, so it had to be, femoral or above. And this was looking at a Norwegian population. Conventional treatment, again, was just sort of low molecular weight heparin and warfarin and compression stockings for 24 months. And the primary outcomes they were looking at were frequency of PTS at 24 months and iliofemoral patency at 6 months. And of note, they did also use adjunctive angioplasty and stents to establish flow for those that had less than 50% residual stenosis. greater than 50% residual stenosis at the discretion of the interventionalist. So in this study, a similar number of patients recruited. It's about 209, similar mean age of 51.5. For the number of patients on oral anticoagulation at 6 months, it was a little bit more in the catheter-directed thrombolysis arm, 61 versus 52%. And at 24 months, 65 versus 50%. It's interesting, there wasn't great catheter-directed thrombolysis outcomes in this trial. Only about 43% had complete lysis, 37 had partial lysis, and 10 patients actually had less than 50% lysis achieved, which is interesting because they had really good results, whereas some of the other ones didn't, but we'll go through that after. And of the patients who did receive thrombolysis, 39 patients had adjunctive endovascular therapy, of whom 15 also had venous stents. This is sort of the patient population here on the right side. So in the end, 90 were included in the intention to treat for the CDT arm and 99 in the standard treatment arm. So in terms of the actual results, so I have here sort of the general patient population and some of the characteristics. Again, age very similar, like I said, compared to the other study. In terms of iliofemoral deep vein thrombosis, it was about 42% or 34%. And then femoral deep vein thrombosis, only 59%. So more femoral than those that were higher up. And then also of note here, for the Norwegian population, as would be expected, you can see that those who had heterozygous factor V Leiden polymorphism was 26 and 22% in the two arms. So quite high burden of thrombophilia in these populations. In terms of the actual results, so that's shown on this table here, there was also in this trial a risk reduction, absolute risk reduction of PTS at 24 months of 14.4% with a number needed to treat of 7. So that's actually quite good still. And severe PTS was only one patient, and that was in the control. Arm. There was also an 18.5% increase in iliofemoral patency at 6 months in the catheter-directed thrombolysis arm. And so, yes, and then of course bleeding. There was significantly more in the catheter-directed thrombolysis arm. 3 were major bleeds and 5 were clinically relevant, as would be expected. And all the bleeds were really, all the major bleeds were in the context of receiving thrombolysis. The overall conclusion from the CABINET trial, as well as from the Torpedo trial, and at this point, was that there seemed to be less PTS, there seemed to be increased patency. There was a lot more bleeding, of course, the CABINET study. It wasn't really talked about the Torpedo study, but guidelines at this point were still saying maybe don't do catheter-directed thrombolysis for everybody, consider it for some patients. Along came the ATTRACT trial in 2017. This was looking at pharmacomechanical CDT for DVT. They were only looking at symptomatic proximal deep vein thrombosis from the superficial femoral vein up. And again, for patients who did receive thrombolysis, stenting was encouraged for lesions causing greater than 50% narrowing of the vein, for robust collateral filling, or a mean pressure gradient of greater than 2 millimeters of mercury, sort of across any kind of stenosis. The primary outcome was PTS between 6 and 24 months. Secondary outcomes were major non-PTS treatment failure, defined as unplanned endovascular procedure, venous gangrene within 6 months, amputation within 24 months, and the safety outcomes were bleeding, recurrent VTE, and death. So this was a bigger trial. It was able to get 692 patients. So this is about 3.5 times the size of the other trials that we looked at. Very similar mean age, similar distribution in terms of the sexes, 78% Caucasian, median BMI, slightly obese. And we can see that they were anticoagulated on average for about 211 days in the intervention group, 231 in the control group. And about 48% of the about 50% of the patients overall were still in anticoagulation at 24 months. The median thrombus removal was about 76% in the intervention group, and on average completed 1 day after randomization. And just look at the types of treatment they received in addition to the pharmacomechanical thrombolysis, you can see that about 28% of patients also had a stent placed here. So for the results, interestingly, and different than the previous two trials, they did not show a significant difference in PTS between the groups at 24 months. So we can see early on there was a statistically significant difference in PTS symptoms, but this did not persist to the 24-month mark. So we can see here that really once you hit 24 months, there's really very similar rates of PTS between the two groups. It did, however, show a decrease in moderate to severe PTS in the interventional group with an absolute risk reduction of 6%. But this is a significantly smaller amount than was seen in the previous trials. There was some increased major bleeding, but the degree of major bleeding was only 1.4% or 2% greater for major bleeding and any bleeding, and was really only seen in the first 10 days. This bleeding risk did not persist, and there was no statistically significant difference in recurrent VTE or death. After this trial, I think people were a little bit more concerned, saying, there doesn't seem to be this as persistent of a improvement in PTS, although moderate to severe did seem to show some improvement. And finally, the most recent trial looking at catheter-directed thrombolysis and proximal DVT was the CAVA trial published in Lancet in 2020, or Lancet Hematology. So again, a multi-center RCT across 15 hospitals in the Netherlands. The patients were first-time acute iliofemoral DVT patients, and they were either treated with ultrasound-accelerated catheter-directed thrombolysis with urokinase, or they were just treated with standard anticoagulation, compression therapy, early ambulation. And the primary outcome this time was again PTS. This is at 12 months, so sort of in between the other studies, and looking again at recurrent VTE, in-stent thrombosis, death, health-related quality of life, and major bleeding. Again, similar age as the other trials, equal men and women in this trial. Median symptom duration at inclusion was about 6 days, 52% provoked in the thrombolysis group, 43% provoked in the standard treatment group. And about 55% of patients in the intervention group also received adjunctive therapies. Of the 42, 35 received vena stenting, 29 in the common iliac vein. In terms of the actual trial results here, so we can see that there was really a numerically reduced number of patients who had post-thrombotic syndrome, particularly of the severe cases, so 4 versus 3, but this was not statistically significant. Numerically also reduced number of ulceration at follow-up, but again, not statistically significant. And there was no difference according to the per protocol analysis either. Looking at the additional outcome, yes. However, even though there was no benefit for PTS, there was significantly more bleeding as expected in the intervention group. It was not statistically significant, but numerically it was higher in the thrombolysis group. There was no significant difference in terms of the events of VTE, so PE or recurrent DVT. But there was, of course, in-stent thrombosis for those few patients who did receive stents. And so that did confer some additional risk. So in the end, they had 18% of patients in the intervention group who ended up having thrombotic events of some type. So how this translated into the actual guidelines between all of these different studies, the CHEST guidelines of 2021 basically said, in patients with acute proximal DVT of the leg, they suggested anticoagulant therapy alone over CDT. They did say, of course, that there are certain patients who would benefit, but that overall, based on the risk of bleeding and the unclear risk of improvement of PTS, they ultimately said, for most patients, not recommending CDT. This is the evidence profile they put together with all the studies that they included, with the largest studies and the most heavily weighted studies being the 4 that I talked about. And we can see there is a decrease when you put everything together in the risk, the relative risk of having post-thrombotic syndrome between 6 months and 5 years with a RR of 0.78. And also for 5 years and above, a RR of 0.56. So there does seem to be some overall benefit, but that is at the cost, of course, of major bleeding. There is no difference between the two arms for PE or all-cause mortality. The ASH guidelines published in 2020 see something very similar. So per the recommendation outlined here, it says, in most patients with proximal DVT, the ASH guideline panel suggests anticoagulation therapy alone over thrombolytic therapy in addition to anticoagulation. They do again say there are selected patients who are younger, have low risk of bleeding, have very symptomatic DVT, or at higher risk of more severe PTS, who may benefit from the use of thrombolysis. And they really just sort of say here in their body of text that there is no good correlation between radiographic improvements and clinical improvements at this time. So that is the evidence for sort of proximal DVT and the guidelines say about proximal DVT. And now I will go into why MTS is a little bit different. So these are all small studies. They are mostly retrospective. And the aim of these studies is mostly to prove that long-term patency can be achieved with stents and to hopefully look for improvement of symptoms. First, I'm going to talk about why MTS is thought to be different than other types of VTE. So why this disease process is thought to be different and thought to be needed to be treated differently. So the Journal of Vascular Surgery published a paper in 1998, which a number of different review articles have quoted. It was done by Volker, Mickley, et al. And it was basically a prospective study on stent insertion in patients with iliac thrombosis, severe VTE. And it was comparing two things. So it was first comparing patients who received thrombectomy without stent insertion to those who did receive stent insertion, and then also comparing those who had venous spurs to those who did not have venous spurs. And the reason that they did this in a time interval, so 1990 to 1994, 1995 to 1996, because in 1995, they had a large change in their center's guidelines for treatment of patients with iliac stenosis. And they basically said that in patients with iliac stenosis or signs of MTS, they did recommend stent insertion at that time. So there was a big change in their mentality in 1995, which is what sort of drove this paper to be done. And we can see here, so this top line, so there's 22 patients with May-Thurner syndrome and thrombectomy with no stent. And if we compare that to patients to 2015 and 2016, there were 8 patients with May-Thurner syndrome, thrombectomy, and stent placement. And we can see that there was 73% recurrent thrombosis in these 22 patients with no stent, and only 12.5% stent occlusion or recurrent thrombosis in the 8 patients who had stent implantation. This is not a randomized trial, so we have to obviously keep that in mind, but these numbers were very different, of course. If we compare these patients who did not have a stent placed with and without MTS, we can see that the risk of recurrent thrombosis is much lower. So 73% in those who did not have a stent and had thrombectomy with MTS, and only 4% in those who did not have MTS with no stent. For those 27 patients without MTS and thrombectomy with stent implantation, it was very similar to sort of before, so 7% risk of recurrence or stent occlusion in those who did not have MTS. So clearly, these patient populations seem to present differently and seem to respond differently to the presence of stents. A more recent study done in 2019, published in the Annals of Vascular Surgery, was looking at the role of May-Thurner syndrome in recurrent thrombosis after catheter-directed thrombolysis. So they really want to say, like, patients who have May-Thurner need catheter-directed thrombolysis more than patients who do not have May-Thurner syndrome. I think that's sort of like the purpose of doing this investigation in the first place. And so we can see from this study, it was a retrospective observational study in patients with iliofemoral DVT treated with CDT. There was only 82 patients, 36.4% with MTS. Average age was quite young, so about 35 years old. but 91.5% of complete clot lysis. So very, very good results with their CDT. And the follow-up was about 91.7 months. And we can see here, so this is a chart looking at primary patency in patients without MTS. That's this upper line here, and with MTS, and that's this line here. And we can see that the primary patency is significantly lower for those who do have MTS. And so in their assessment, they looked at age, they looked at sex, they looked at provoking factors, and sort of different predictors of patency with time. And the presence of MTS was the only significant predictor of patency, with an OR of 2.879 and p-value of 0.04. And so the conclusion from these two is that MTS probably is somewhat different than just a standard DVT, and therefore does warrant different treatment despite what the guidelines say. So what is the evidence then for actually treating patients who do have MTS with catheter-directed thrombolysis? This is a single center RCT that was, so I will say that the evidence is overall quite limited, but this is a single center RCT completed in 2013, and it was assessing those treated with CDT alone versus CDT with stent placements in patients with iliac vein obstruction secondary to what is thought to be May-Thurner syndrome. They had 74 patients enrolled overall, 45 who received iliac stents, 29 who were control patients and only received CDT. And they did find amongst this population that the patency of the iliac vein was 87.5% in those who received the stent and only 29.6% in those who did not. So very, very significant difference. And you can see that in this cumulative patency rate curve here. At 1 year, it was 86% versus 55%. So you can see significant ongoing drop off and increasing risk of recurrence with time in the control group compared to the stent group. This is another trial that was published, the Atomic trial, published in 2019 in the Cardiovascular Intervention and Therapeutics paper. And it was a more contemporary retrospective assessment of 59 patients who were treated with stents for left iliac vein stenosis with acute DVT. And the real purpose of this paper, they really just want to show that, putting stents in patients with May-Thurner syndrome, you do get good results, you have good patency, and it's safe to do. And so in their patients, they had 95% patency rate before discharge. All patients of note were treated with at least 6 months of anticoagulation. 10% had bleeding complications while they were treated in hospital. And then 90% were treated on warfarin before discharge. When DOACs came around, they were sent home on DOAC, but that was a little bit later on in the trial. And 25% of patients were on both anticoagulant and antiplatelet therapy. In terms of the actual results, so they had 1 DVT recurrence secondary to stent occlusion of those 50 patients. So we had results for long-term results for 50 patients. 2 who had DVT after cessation of anticoagulation, and both these patients had autoimmune disease. And there was some chronic occlusion seen in about 9% of patients, or 4 patients, sort of distributed between 6 months and 21 months. Assessment for PTS was completed in 36 patients, and we can see that those with stent occlusion had much higher rates of PTS compared to those with patent stents. So 33% versus 4%. But again, this is a retrospective trial, it's limited, and the number of patients who had stent occlusion was very small compared to those who had patent stents. This is a trial that was published in 2017 in the Journal of Vascular Surgery. And what they were looking at here was outcomes after venography-guided treatment for patients with May-Thurner syndrome. So essentially, they had 63 patients here, 31 patients with thrombotic MTS and 32 with non-thrombotic MTS. And they were 5 of 31 patients with MTS were treated conservatively, so without stenting. And they wanted to just look at sort of the results of those patients compared to those who had thrombotic MTS treated with stenting. These patients who did not receive stenting were treated with anticoagulation and single agent antiplatelet therapy. Oh, sorry. Those who did receive a stent were treated with anticoagulation and single agent antiplatelet therapy afterwards. So this is a summary of the results, looking at those who were stented versus those who were not stented, those who were thrombotic versus who were not thrombotic. And the real thing that I want to point out from these results is that there was clinical improvement in 95% of those who were stented and only 58% of those who were not stented, and complete symptom resolution in 64% of stented patients and only 21% of non-stented patients. So it was felt that there was significant differences between these two groups, though this was again not randomized. And we can see here, so this is sort of the venography results between those who were stented and not, and they were very different populations. So a lot less occlusion, a lot less collateralization, a lot less stagnation in the non-stented group. But despite those things, they still had worse outcomes. So sort of points towards doing more generalized stenting for all those who do come in with MTS. Okay, so that's all that I'm going to talk about for endovascular procedures and a lesson on basically interventional radiology. So in general, endovascular therapy does not seem to confer definite benefit in patients who have proximal DVT without MTS, but MTS does seem to be a different population and does seem to have some benefit to have endovascular procedures, particularly stenting and CDT compared to other populations, or the more general population who does not have MTS. So the next question that we often get asked, so these people get stented and then vascular surgery, sends them to us and says, what should we do for anticoagulation and for how long? And I think that this is a challenging question that honestly we don't have good answers for. So I tried to look into that. And to be honest, there really is not good evidence for this. There was a systematic review that was published in the Journal of Thrombosis and Hematology back in 2021. They looked at 207, they basically looked at 64 articles. The primary patency rate was sort of 82.3% 1 year post-intervention, 73.3% 2 years post-intervention. Most studies used vitamin K antagonists for anticoagulation, 18% with antiplatelets, 59% without antiplatelets, and they were not specified for the other percentage. And only 2 studies of all of these studies looked at the effect of duration of antithrombotic therapy on treatment outcomes. Overall, their conclusion was that the impact of post-interventional antithrombotic therapy on stent patency remains unknown because there's limited and insufficient data in current literature. Another paper that basically had very similar results was published in the Research and Practice of Thrombosis and Hematology paper back in 2018, a systematic review looking again at stent occlusion and systemic anticoagulant use. There's only 5 studies included. They were all retrospective, and they included only 61 patients in total. And of those, basically, they showed that those treated with 6 months of warfarin had 78% patency. Those treated with more than 6 months of warfarin had 89% patency. And those who was not very well specified with variable anticoagulation or long-term anticoagulation without antiplatelet therapy had 81% patency. So they basically said you can expect about 10% to 28% of patients to have post-stent placement regardless of antithrombotic management. So really unclear if there's a true impact, but there's really not adequate studies done looking at this. And of note, the INR target for these studies was 2 to 3 for all studies except for 1. This one study was looking at a pediatric population and had a target INR of 1.5 to 2.5. Because this question was so not answered, someone named Kay Molinis published a paper in the Journal of Vascular and Endovascular Surgery in 2018, and basically presented this scenario of a 25-year-old who is found basically to have May-Thurner syndrome and gets a stent put in, and what they would recommend for anticoagulation afterwards. And you can see here that there is really no consensus for what patients should receive and for how long. 29% of patients, which is most common, said low molecular weight heparin for 6 weeks, then warfarin for 6 months. 60% said DOAC for 3 to 6 months. 60% said antiplatelets for 12 months to lifelong, but there was significant variability in regards to what the recommendations were post-discharge after having the stent put in. And really the conclusion is that more research needs to be done in this arena. Finally, the last slide I will be going through is the factors related with recurrence. This was published in 2019, the Journal of Vascular Interventional Radiology. It was an observational retrospective study of 59 consecutive patients over 17 years at a single institution. And they were all treated with an endovascular stent for diagnosis of MTS. Of note, 15% of patients did not have a DVT, so it was just for chronic venous insufficiency. And the only real thing that was associated with recurrence was poor venous inflow or outflow and a high degree of in-stent stenosis that predisposed to recurrence. So age, sex, race, tobacco use, renal insufficiency, coagulopathy, none of those seem to be as closely related to recurrence as sort of the outcomes after stenting procedure. All right, so that was a large talk about May-Thurner syndrome, as well as a little bit of an excursion going into catheter-directed thrombolysis and general proximal DVT. So my conclusions that I actually want you to take away from this talk, I think just think about May-Thurner for your patients with unilateral chronic venous insufficiency symptoms, proximal iliac thrombosis, who are young and who have recurrent thrombosis. The gold standard for diagnosis is IVUS. And again, I honestly do not know if this is something that's available here in Vancouver, but otherwise radiography is quite comparable, and CTV and MRV are also both sensitive and specific. Current guidelines, I think we have to keep in mind, don't specifically pertain to MTS, and MTS probably does behave a little bit differently based on the small trials that we have that again aren't RCTs, are just sort of retrospective or small prospective studies. There does seem to be benefit in the studies that we have available that again are limited in reducing post-thrombotic syndrome, reducing recurrence in patients treated with CDT and stenting who have MTS. And the treatment guidelines for anticoagulation are extremely unclear. So we generally say treat like any other DVT. You may be able to start anticoagulation after a stent is inserted, but it's sort of, I think, up to you to decide with your patient based on very little data that's actually available. Thank you.